is from the Seattle VA. She's a geriatric psychiatrist. She is fantastic. She is the program director for the Geriatric Psychiatry Fellowship over there. And she gave a great talk on suicide in older adults for our geriatric medicine grand rounds. That was very well received, and I thought it would be a great topic for us to talk about in ECHO. So she's willing to give us an abbreviated version of that talk here, and thank you so much for doing that.
No problem, absolutely. Thank you for having me, and it's always a pleasure to get to join you guys and try to communicate a really important topic, hopefully have a good discussion on how we can work with our older adults with regards to suicide risk. I guess I'll just go ahead and jump in and get started, and I just control the slides. Great. A lot of you probably heard there's a lot of news in the past year about increasing suicide rates across the US. And I know for me, a question was, how does this pertain to my older adults? This particular slide is found or can be found on the CDC website, and it's broken down with regards to suicide rates by gender and age. This particular slide specifically is for women, comparing suicide rates in 2000 and then 2016. The big headline this past summer was, a 30% increase in suicide rates overall. And in women, it was particularly high in the middle age range. What's interesting about this slide is we can see that our older adults also had an increase in terms of our female population, specifically in the 65 to 74 age range. 75 and older didn't really increase statistically, but still remained, at least it didn't go down in those 16 years. Next slide describes the means by which women who die by suicide completed suicide, and you can see it's sort of across the board in terms of means. The specific ones that are listed here are firearm, poisoning, suffocation, and other. And again, it's sort of a little bit of everything. And this is actually not that different from what we all probably learned in school, medical school, or other training programs, back in 2000. I think for men, it's again pretty striking. Suicide rates increased again overall, again in that middle age range, 25 through 64. What's interesting here is that the rate of increase between 2000 and 2016 did not go up in men ages 75 and over. It actually went down a little bit, but the overall rate was still much higher in our 75 plus group. So again, from 2000 to 2016, rates in general went up. In older adults, rate didn't increase, but still remains high and kind of dwarfs all the other age ranges. In terms of means, what's particularly striking here is the use of firearms in older adults. It continues to be the predominant means by which they complete suicide. Again, age 75 to 74 and 75 and over, again, predominantly firearms. Quite different from women, also from the younger folks. So I included those slides because I wanted to highlight that there were changes in suicide rates over the past 15 to 20 years. And unfortunately, those changes were not in the positive direction and did not positively impact older adults. It highlights, again, what we've known before, but seems to be a continuing trend that older adults, particularly older men, are choosing lethal means, specifically firearms, more than others. Here are a few other sort of tidbits or factoids that comment further on this issue of lethal means. It's commonly, these are sort of commonly thought or proposed or kind of cited statistics here. In adolescents, there are as many as 200 attempts per one death from suicide, as compared to older adults where there are just 2 to 4 attempts per one death from suicide, which really just shows that older adults are completing suicide with their first or second, third try, as opposed to in adolescents or younger people where there may be more attempts versus completed suicides. Why the discrepancy? There are a lot of ideas. The big one that a lot of us think about is the choosing of more lethal means, specifically firearms. Also, older adults with specifics to their underlying physical conditions might make it more difficult for them to recover from significant trauma or illness, such as frailty or other physiologic issues. So now that I've highlighted a little bit of the sort of demographics issues, the numbers, I think about next, well, now that I'm in the office, what do I do? I'm working with an older adult with maybe risk factors. What can I do to help that particular patient kind of combat or beat the odds, so to speak, that we're seeing in the numbers? Traditionally, we think about suicide risk assessment in a three-step component, and it's actually spread across disciplines. You think about a screening, usually by a nurse in the ER, in the primary care clinic. That screening is positive. Medical provider, either an ER doc or you guys in the primary care office are alerted. You may do your own assessment and treat as appropriate, if appropriate, but usually often there's a referral to a psychiatric specialist, and there move on to appropriate treatment. I want to raise a few caveats before I jump into sort of the practicalities of the suicide sort of screening and assessment sort of approach. The caveat here is that when we're talking about these processes, so risk identification, evaluation, and management, these are all adapted from work from younger adults. We don't have a lot of good work looking at specifics in older adults. So I and a lot of us have open questions about to what degree are these processes applicable to older adults. First of all, lethality. Are the ways that we're using to identify younger individuals similarly effective to older adults? Does suicidal ideation in older adults correlate with higher risk of attempts? Sometimes we think about older adults talking about dying or death and dying in a normative way, and to what degree is that or other sort of ways that we sort of screen for thoughts of suicide necessarily correlating to completed attempts. Also, on the flip side, how willing are older adults going to be with regards to reporting their thoughts of suicide, even if we do screen universally? So there's some open questions, no answers. As I move on into, as I talk more about the sort of processes of suicide risk assessment and all that, just keep those caveats in mind and adjust as you see fit with regards to your patients, because that's all what we are doing in psychiatry. So I'll start with a PHQ-9 as a screening measure. It is widely accepted to use the PHQ-2 version, which is just the first two questions in the PHQ-9. As you're probably all familiar with by now, the PHQ-9 is a 9-item sort of list of symptoms that asks our patients to rate the severity on a Likert scale. And the first two questions are screening questions primarily for depression. Are you, in the past 2 weeks, have you been bothered by little interest or pleasure in doing things, feeling down, depressed, or hopeless? A lot of us are now including the 9th question, which is, are you having thoughts that you'd be better off dead or hurting yourself in some way? It used to be that we would ask the first two questions, and then if any of them are positive, move on to the 9th, but more and more we're moving straight to just including all 3. This is something that's pretty easily done, at least where I work, is done kind of when people are in the ER or where they visit a primary care physician, and where I work, they're pretty much doing it, I think, annually. So it's pretty straightforward and quick, and can do that initial sort of RN screening, fulfill that role, that initial RN screening. There's something else that's in the literature called the Columbia Suicide Severity Rating Scale, or the C-SSRS, and this is nice because it's really well supported by literature. It's freely available, and there are multiple screener sort of versions available to lots of different providers, not just medical providers. So first responders, people who work in schools, friends and family, parents, of course, our healthcare providers. As you can imagine, because it's thought to be useful for all sorts of sort of environments or situations, this has also been nicely validated in children, teens, and also those with cognitive impairment. This is the screening version. So that, just a caution, the rating scale is actually, when used in the literature, is really long, kind of bulky, a little bit tough to manage rating scale, but it does have a pared down screening version, which I have on this slide, which is nice in that it gives you those initial screening questions or equivalents that you saw in the PHQ-2, but a little bit more detail and uses questions that I often like to use anyway. So I thought I'd include this so that you can adapt it to your own practice if you feel like this can be helpful for you. So ask kind of similar questions, just screening for the first two. Have you wished you were dead or wish you could go to sleep and not wake up? You can kind of normalize it a bit if you like. You know, we've been talking about how you've been feeling really bad recently, or you've been talking about a lot of health conditions. You know, have you ever reached a point where you felt like, you know, feel like you'd be better off dead, or you didn't want to wake up the next day? And then you can follow up, well, has that, if yes, you can follow up and say, well, has that kind of progressed? Actually, any thoughts of killing yourself? And if they say yes, then you ask them a little bit more detail. All right, you've mentioned you've had some thoughts of killing yourself. Have you thought about, has it got to the point where you've thought about how you might take your own life? Or now that you've had these thoughts, have you thought about you know, moving forward? Do you have any intention on acting on them? And then finally, if you started, you know, asking about whether they've actually started to work out details and do they actually intend to move forward. The last question is included because people who have a history of suicide attempts are at higher risk for moving forward with a second or a subsequent suicide attempt. So that particular question is asking if someone has ever actually done anything, started anything, prepared to do anything to end their own lives. Okay, so after, those are two examples of ways you can screen for suicide, suicide risk. After screening, if positive, then we look at an assessment. And I just wanted to give you a brief overview of what a lot of us in psychiatry do. I was a little bit concerned that SAMHSA had a kind of what's the word, sort of reduced a comprehensive suicide assessment to 5 easy steps, but that's what they did. And it's actually kind of interesting how they've done it, and actually fits things pretty well. SAMHSA publishes this sort of pocket card on the suicide assessment in 5 easy steps. Or I mean, I shouldn't say 5 easy steps, five steps. They may not necessarily be easy. So let's say your nurse has screened positive, nurse has done a screening and screened positive for concerns about thoughts about suicide. So what kind can you do in the office to get a better sense of what that risk is? The steps include identifying risk factors, identifying protective factors, kind of conducting a suicide inquiry, which you might have done already if you did do the Columbia screening assessment. Then, based on those risk factors and the suicide sort of questioning, determine a risk level, and then at that point decide your intervention. And of course, document that you've done all these things. Risk factors, if you were to ask any of us, the risk factors or sort of suicide research field identifies these pretty long lists of risk factors, and sometimes it's hard to keep track of them all. I thought I'd include just ones that have been highlighted as geriatric risk factors. We often divide risk factors into static risk factors and then dynamic risk factors. Static ones meaning ones that are not changeable, but dynamic ones that are ones that we could potentially address. So here's a list of geriatric static risk factors. So of course, advancing age by definition, race, Caucasian, gender male, past history of suicide attempts, past history of abuse, also a family history of suicide, and chronic medical illness, unfortunately, are static risk factors that are by definition more difficult to address, but our dynamic risk factors are ones we could potentially address. So current psychiatric illness, depression being common, but actually any psychiatric illness counts. Psychological symptoms that you probably have heard about, or heard from your patients talking, or heard your patients talking about, burden, feeling like they're a burden on others, feeling guilt, hopelessness, sort of on a separate level, impulsivity and poor perception of health have been identified as psychological symptoms associated with higher risk. And keep in mind, it's a poor perception of health. They might actually have relatively good health, or you might have patients with what you would judge to be maybe poor health, but they do not have a poor perception of health. So it's the perception of health that's the issue. Of course, acute medical illness, substance use, access to lethal means, financial stress, and social isolation. I'm sure you can visualize many of your patients who are challenged with these types of risk factors. The third step in the SAMHSA card, or was it I'm sorry, the second step, the SAMHSA card was identifying protective factors. And here's a list of geriatric protective factors. strong sense of social connectedness, fewer medical comorbidities, so they're kind of the opposite of the risk factors that I mentioned earlier, no history of prior suicide attempts, being active in the community, not socially isolated, and strong family support and geographical proximity. So the way I look at this is social connectedness, social interaction, or sort of sense of being in a community seems to be a really strong protective factor, or the lack thereof can be a risk factor. Now, part of the reason I go through this list and why it seems important is because when I start talking about treatment, we're going to be looking at actually primarily ways to address or reverse or change risk factors, if at all possible. All right. So the next step on the SAMHSA card, after identifying risk factors and then inquiring about suicide plans and intent, is to go ahead and try to do an evaluation of a level of risk. And in this table, it just sort of summarizes. So this is actually the backside of that SAMHSA card. If someone has, a lot of modifiable risk factors, but a lot of strong protective factors, and the thoughts of suicide are rather vague, they don't have plan or intent, they can probably be managed in the outpatient. Working on reducing those risk factors, give emergency crisis numbers a safety plan. As we move into the moderate stage where someone has fewer protective factors, more risk factors, their thoughts of suicide do have a plan, but maybe not an intent, or they haven't engaged in preparatory behavior. You're kind of on the fence. Admission may be necessary if you don't have the resources to treat as an outpatient. But some of us, if we are resource rich, for example, where I work, we have an intensive outpatient program. This could be a good fit for someone who can get that step up in mental health care and do fine with that and be safe with that. For those who have a risk level high, these are people with severe symptoms, severe psychiatric symptoms. Protective factors really aren't present or not relevant. They have high suicidality in terms of their ideation and intent and planning. And at that point, we're strongly thinking admission. All right, so I hope I gave you a good summary of what I typically do in terms of the suicide risk assessment and what you may feel comfortable incorporating in your practice. I actually hope that you never have to do this, that you always have a mental health provider to be able to do this for you. But I do understand that you may be working in environments where mental health support is difficult to find. Really, really briefly, I'll talk about treatment. We tend to focus on addressing modifiable risk factors, treating psychiatric disorders and those psychological factors that I mentioned earlier, sense of being burdened, guilt, things along those lines. So psychotherapy, obviously I work a lot with psychiatric medications or other biological treatments like TMS or ECT, and substance use treatment. We also look at means restriction. I certainly encourage social connectedness, again, because of all the protective factors, including social connectedness. And safety planning. Real briefly, this is something that you can look up online. A lot of us are now using a suicide safety plan. It's also sometimes called a suicide prevention plan. And again, this is not a safety contract or anything. It's really just something that you can go over with the patient, write it down so that when they are by themselves, feeling like they're in crisis, they actually have something in their hands that they can follow. These plans usually include a section on warning signs, a section on internal coping strategies that they can try to facilitate on their own, a list of people that they can contact just to get their mind off things, and a list of people who they can trust to really talk about their crisis, and then finally mental health providers that they might be in contact with, or emergency services like a crisis line going to the ER. And often there will be an inclusion about restriction of means, so talking about, all right, you're feeling a little bit worse, let's get the ammunition separate from the guns, or keep things locked in a safe, and ask a loved one to make sure that your guns or your stockpile medications are not easily accessible, things on those lines. I know I'm running low on time. I really wanted to include this. This was a survey done by, I want to say, yes, the CDC back in the early 2000s, a telephone survey. And this particular graph includes older adults. It's almost 30,000 older adults, and asked them about whether they had guns in the home. Left-hand slide age range, you can see, probably a third of our patients age 55 or older have a gun in the home. On the right side, I don't know if you know the 5 L's of gun sort of safety assessment, you know, are the guns locked? Are they loaded? Are there little children in the home? Are you feeling low or depressed? Are you a learned operator? Maybe haven't had any training. You know, 20% of people in this age range have firearm that's locked. I mean, and that's not locked and is or loaded. Let's see, 9% have people with children under the age of 18 in the household. Only 50% of people reported having training. Again, this is in older adults through a very large telephone survey. So I want to throw that out there for your, so that you're aware that many of our patients do have guns. Okay, just finally a slide on resources for patients. I wanted to include the Suicide Prevention Lifeline and the Friendship Line. The Friendship Line is a sort of a crisis hotline, but can also act as a warm line for non-emergency emotional support calls. This is a line focused just for people age 60 and it's run out of a nonprofit in California. And I'd actually contact them and ask them, can anyone call? And they said, actually, anyone can call. So if someone is not, they don't necessarily have any crisis, if they're feeling a little bit lonely or would like to have an emotional support call, they can get that call as well. All right, I just squeezed a big topic in a small amount of time. I appreciate your attention. I'm happy to take any questions.
Thanks so much. Yeah, if anyone has any questions,